Okay, so all of you are here today for the ACEs screening implementation training for the National Pediatric Practice Community on ACEs, which is NPPC, the program that we're at here at Center for Youth Wellness. So I would love to take a moment to just introduce my team with me. First, I'm Mernell Gomez. I am the Training and Technical Assistance Manager here at Center for Youth Wellness. And with me today, Lena, if you'd like to introduce.
Hi, everyone. I'm Lena Singh. Great to see some familiar faces over there. We visited your clinic in June. I'm the Program Director for the National Pediatric Practice Community at the Center for Youth Wellness.
Wonderful. And then Carissa will be providing the ACEs screening protocol. Carissa, are you available?
Yes, I am. I'm just trying to get my camera working. There we go. Here. Now, I'll get the lighting adjusted for everyone in just a moment, but good morning. So good to see all of you again. It's been a while, but we're so excited to get the training done today so you can start screening.
Great. Thanks, Carissa. So for most of the sections, we're going to be showing the slides. So I'll ask folks to be off camera just to be less distracting. And so if anyone's joining us that isn't with you all today, please do the same and keep your lines. Okay. Okay. For CMEs, this is information here. So medical providers, you would receive 1.25 credits, and then for other professionals, it'll be 0.1 continuing education units or 1.25 contact hours. So again, even if you're not sure if you could qualify for that, we are still being asked for everyone in attendance to please register. A link was provided in the calendar invitation as well as sent out. Kelly, I believe you received it. Please make sure that all of you present register if you haven't done so already. Here's the team. What are we in for? So we have about an hour and a half, give or take, and we're going to be reviewing more detail about our program and partnership engagement, reviewing the science of ACEs and toxic stress, orient providers and staff to ACEs screening, rationale and protocol development, and discuss screening protocol and practice with sample scripts, then reviewing education tools, documentation, and additional resources if applicable. Before I get into NPPC, I would love to give you a little bit more information about our organization. So Center for Youth Wellness is a pediatric organization based in San Francisco. We are focused on early childhood adversity and addressing adverse childhood experiences in pediatrics. We are excited to work with all of you to improve care for patients and families affected by ACEs and toxic stress, and work to transform how the field of pediatrics addresses this issue. We'll briefly talk about how adversity plays a role in a child's life and how they can be resilient to it. And being able to predictably and compassionately be available for children will help their resiliency. Using a formal screening tool will support and evaluate how best to do this process. So NPPC is a learning community of pediatric medical providers who are leaders in advancing clinical practice around ACEs and toxic stress in primary care. Our goals are to engage providers as champions on this issue, provide tools, resources, and training, and coaching needed to make ACEs screening and the integration of a toxic stress framework a reality in practice, and to ultimately become a hub for learning about ACEs and toxic stress as they relate to pediatric medicine. Our vision is that all primary care pediatric medical providers implement universal screening for adverse childhood experiences, or ACEs, and routinely use an understanding of ACEs and toxic stress to enhance the quality of patient care and health outcomes. So this project currently has a few different areas of work. We've convened a virtual community of medical providers interested in this topic, and we also provide direct technical assistance and training directly to medical practices to implement ACEs screening. So having one practice teach another as it gains traction nationwide. And as of May this year, we have 1,000 members in this network since launching 2 years ago. All members have access to our member website. And this is why we ask for all of you to please let us register you for this, because this is the MPPCACES.org. It's a virtual network committed to building a national community of medical providers using an online platform to promote shared learning, disseminate best practices, and cultivate advocates in the medical community. So you'll have a comprehensive resource center for tools and materials to support your screening implementation. And you'll also receive newsletters and announcements for upcoming events, such as webinars and up-to-date information from the field. So we truly value our partnership. This practice has yet to adopt an ACEs screening protocol, so we provide tailored support, training, technical assistance, and coaching around all aspects of developing and implementing this protocol. We know that implementing screening can be complex, so we have the expertise and tools that can help your practice implement screening in an effective and efficient way. So now that you have some context, I'd like for us to build a shared understanding about the science of ACEs. ACEs, or adverse childhood experiences, are potentially traumatic events experienced before the age of 18. The term ACEs comes from the Adverse Childhood Experience Study, or ACE study, conducted in 1998 by Drs. Vincent Folletti and Robert Anda. It was one of the largest investigations ever conducted to assess connections experiencing adversities in early life and having outcomes as an adult. This study is the basis for the 10 core ACEs you see over here, often characterized in 3 categories. 1, abuse, 2, neglect, and 3, household instability. They include physical, emotional, and sexual abuse, physical and emotional neglect, and living in a household where a member has a severe mental illness or substance dependence, where the child has witnessed violence against their parent, or where there has been separation from a caregiver due to incarceration, shifting parental relationships, or divorce. Many ACEs screening tools screen for additional adversities in addition to the core ACEs you just saw. These additional adversities include hardship or significant life events such as the death or illness or a separation from a caregiver, forms of violence and bullying, and discrimination. These experiences may impact a child's health in the same way as the 10 ACEs. Therefore, screening for both ACEs and additional adversities provide a more comprehensive assessment of risk factors for long-term health in a child by combining both individual and community environment level health items. Okay. So this slide over here shows that the ACEs study is striking. ACEs are incredibly common among the population. So over 2/3 of the adult population have experienced at least one ACE. We have data that shows that nearly half of all children today have experienced at least one ACE, and that ACEs accumulates over childhood. So I'll be briefly going over this data, and if there are any questions, please let me know. Here's some data on the state level for North Carolina. You can see here that nearly 24% of North Carolina children have experienced 2 or more ACEs, and almost a quarter have experienced at least one ACE. We have data that compares what a child in North Carolina who has 1 or more ACEs may experience, both good and negative, compared to nationally. Of course, we know that while the prevalence of ACEs is common across race, gender, class, and other groups, certain groups are still disproportionately impacted. Those who might be most likely to experience ACEs may certainly find the adversity exacerbated by environmental and structural factors, such as poverty, racism, and discrimination, plays a role. The ACEs study and subsequent research has pointed to a dose-response relationship, meaning that more that ACEs that someone has, the greater the likelihood of negative health outcomes in adulthood, including the causes of death in the US, heart disease, cancer, chronic lung disease, addiction. So this slide actually shows that those with 4 or more ACEs are twice as likely to develop heart disease or cancer, 3 times as likely to have chronic lung disease, and 11 times as likely to develop Alzheimer's. So we're talking about ACEs as a potential root cause of some of our most costly diseases. But ACEs doesn't just impact health in adulthood. Many of the health and developmental concerns associated with ACEs also appeared during childhood. Among infants, studies have found associations between ACEs and growth delay, cognitive delay, and sleep disruption. Middle childhood, we find associations between ACEs and asthma, learning difficulties, and behavioral problems. And in adolescence, we find association between ACEs and violence, bullying, smoking, teen pregnancy and teen paternity, and weight management. So the question is, how do these early social experiences turn into health-damaging ones? What we now understand is that these early experiences act as a stressor on the body, and in doing so, activate our stress response. So while this stress response is highly adaptive and generally functions well, when it's activated over and over again, it becomes health damaging. So this is a slide that shows the spectrum of stress response, including positive stress, tolerable stress, and toxic stress. The physiologic response to stress depends on the nature of the stressors and the availability of buffering and coping strategies. So a positive or tolerable stress response is characterized by the return to homeostasis, whereas a toxic stress response may induce lasting changes. Toxic stress is characterized by prolonged or frequent activation of the stress response caused by factors such as ACEs that leads to disruption in the way our neuro, endocrine, and immune systems work, leading to negative health impacts. So let's take a look at how toxic stress may impact the body. Some of the neurological effects that can include overactivity and difficulty turning off the stress response, increased fear response, and increased risky behaviors. The immunologic effects can include increases in infections and chronic inflammation. The endocrine effects can lead to changes in hormones related to growth, puberty, and metabolism. And research has also found epigenetic effects, which includes changes in the way DNA is read and expressed, increasing risk for diseases such as diabetes and cancer. There can also be substantial individual variability in how early adversity and toxic stress shows up over the life course. In this image, what we see is different possible trajectories as examples. So first, starting at the very top, you see that it's possible that an individual who experiences ACEs doesn't present any symptoms and ends up having a healthy life. At the very bottom, we see an individual who experiences toxic stress, and we see that disruption manifests as social or cognitive impairment, which leads to the adoption of health risk behaviors and leads to disease or disability. These are likely individuals that those of you who are providers are already identified through your practice as needing extra support or intervention. Those who have behavioral symptoms are in many ways fortunate because they usually receive some sort of intervention. Because here in the middle, we see a child who's experienced toxic stress, but perhaps doesn't present the more obvious behavioral symptoms. Perhaps it comes in the form of ADHD or uncontrolled asthma. So this child has no recognizable symptoms, but as an adult, still experiences premature disability or disease. So this shows the importance of screening, as not one person will experience things in the same way. We know that some individuals do and some individuals don't experience toxic stress as a result of negative experiences. So there's a lot of individual variability. So think of this scale weighing the things, both good and bad, that may affect a person's health. The positive things are called protective factors, things that help create a safe and stable foundation for a child. The other end of the scale holds the bad things or risk factors. ACEs are risk factors. And then there's the fulcrum, the middle part, which is an individual's biology, their genes. Our biological makeup may make us more or less susceptible to stressful experiences, where the fulcrum, the middle section, is positioned on the scale would be different for every person. It affects how much leverage either protective or risk factors have in shaping our life outcomes. So for example, someone who has their scale weighed down by risk factors is also more biologically susceptible and will be at greater risk for stress-related diseases. Okay, so I covered quite a bit of information, but again, this is more of an overview. So I wanted to pause here to see if there are any questions around this topic. I did that good, huh? Okay, so if there are no questions at this time, what I'd love to do is go ahead and bring on Carissa. Carissa is going to be talking about the ACEs screening. So Carissa, you have it.
All right, thank you. Good afternoon, everyone. Hope you're doing well and enjoying some good lunch. So we will talk a bit about the ACEs screening and how we're going to work with you and how we have worked with you to develop a protocol that will hopefully be successful in your clinics. Next slide. So we know a few key reasons why ACEs screening is ideally placed in the pediatric setting. It's an ideal place for health promotion and anticipatory guidance. You guys do that kind of thing every day, so you're well versed at it. And families really desire to have a relationship with their pediatricians, not only in illness, but in pursuing health. So they look to you all to anticipate and recognize milestones in their children. And so helping to understand and know the families is a great way to help build that relationship in primary care. And we see that particularly in pediatrics more so than in adult care. Next slide. So the way we approach ACEs implementation and practices is to view it as a quality improvement initiative. So we do utilize the PDCA model, and as we work through our PDCA cycle, which is 6 months in duration, the P part is when we come on site and we plan and work with your leaders and take a tour of your clinics and just get to know you, your culture, and your community a little bit better. The do part is when we finalize implementation workflow and the operational definitions, and we'll actually be engaged in that initiative today. Over the next 6 months after you go live, we'll be collecting some basic measures to assess your effectiveness in implementing screening and making the appropriate linkages for patients that you identify needing some assistance. And then at the end of that 6 months, we'll be able to summarize the learnings, your data, and any insights we've gained from you in a written PDCA cycle that can be used for additional requirements in your organization or just to track and monitor our progress. Next slide. So as you can see, today we're finishing up the planning cycle. In our PDCA cycle, we anticipate a 1-year closeout. So we'll finish this first 6 months. At the end of that, we'll actually work with you all to see if you're ready to spread screening to other clinic sites, or we need some enhancements, or we need to rework your current workflow to sustain efforts in your own clinic. At the end of that 6-month cycle, we'll have another set of data, and you'll have a complete 2-year data profile available to you. Next slide. So with regard to your specific protocol, we want to provide you some specialized training on what it'll look like in your clinic when you go live. Excuse me. So we know that the key steps to creating a successful implementation screening protocol have to do with making some key decisions early on. Those include identifying a rationale for the patient population you'd like to screen, and then starting with that small group at a specific interval, and to develop a workflow that minimizes the disruption to your current clinic efforts. And then we've identified the screening tool to be used. There are others out in the marketplace. Of course, we're partial to CYWs, ACE-Q, so we'll be talking about that further today. And then creating a specific scoring algorithm for your population, including the very important referrals component, and developing that education and intervention plan. Next slide. So, when we met with you and your clinic leadership, we heard that you have a priority of identifying patients that may need your help and assistance and capturing them or speaking to them while they're on site in the clinic. We heard it's a priority to improve your internal and external systems and create a more thorough and intentional approach around trauma-informed care, and to work on the concept of connecting services and people who are experiencing toxic stress at the right time and at the right level of intervention. We'll be asking you and training you to screen 3- and 5-year-old children at their well child visit. So I just want to point this out. This will be the first page in your handouts too, I believe. This is the ACE-Q screening tool. This is the parent self-report, this is the parent report for their child. So the parents will be filling out the questionnaire based on what they perceive their child's experience has been thus far in their lives. We call this tool a de-identified tool. Now that doesn't mean what we generally think it to mean on the medical side. So we are going to put the patient's name and MRN or whatever you would use to identify the patient on the piece of paper. But what we mean when we say de-identified is that the tool itself asks family members to let us know what experiences they've had, but not necessarily what specific experiences they've had. I'm a bit tongue-tied today, excuse me, I'm so sorry. And in a later assessment with the provider, there'll be some questions around symptoms that are commonly linked to the presence of toxic stress. So on your handout, you can see there's actually a very good explanation on how to fill it out in bold, but we have learned through our experiences in implementing in other sites that for the most effective response rate, you would go ahead and explain how to fill out the tool. It takes about 15 to 30 seconds, and the family may read the directions too, but it does need that reinforcement because we're all naturally inclined to write yes or no. So this is a new way to fill out a form. So we simply ask the parents to read through the questions in the top section, and these include the core 10 ACEs that Murnell spoke to you about earlier, and to write the number that they've experienced in the box to the right. In section 2, you'll see many items that have to do with social need or social determinants. These have been validated and identified to us through a community advisory board, and they are also predominantly discussed in the literature and endorsed by the American Academy of Pediatrics around social determinants and social needs. So this is another set of questions that we feel are very important that you ask. So you would just say to patients and families, you'll just read the items in the top box and write how many you've experienced in the top box on the right, and read the items in the bottom box and write the number you've experienced on the bottom box in the right. You don't need to fill out which one, yes or no, just write the number. All right, next slide. So we want to talk a little bit, now that we've talked about the tool and the rationale and the screening population, we want to walk through the workflow that will be specific to your clinic. So when we were on site, we heard that it would be best if the tool was introduced and handed to the patient caregiver by the nurse when the patient is being roomed. The patient will then complete the assessment or the ACE-Q. The nurse will support the patient in completing that if needed. We understand that you may have families that are not able, or we don't have the tool in a primary language that we speak, although we do have it in English and Spanish, and you might have to help them complete that. So we understand that that might be the case. So you'll support the completion of the screening and document the results in the EMR, and I'll show you where to do that in just a minute. And then you'll transfer that information to the medical provider and hand off any needed information. Next, the provider, the doctor or the nurse practitioner or PA will come in and well, they'll review the screener in the computer if needed, and if they need to, they'll document the results in the EHR if for some reason there was some question about how to complete it. They then will assess the presence of symptoms or not with relation to toxic stress, and we'll look at that in just a moment. And then they'll determine the next appropriate first steps for follow-up, which may be coordination with your referral coordinator, patient education, or an outside referral. Next slide. So we're looking at your scoring algorithm now. So again, I didn't mention this before, but think back or look on your piece of paper that's in front of you, your tool, your ACE-Q. When we talk about the score for the ACE-Q, we're adding the top and the bottom boxes together to get this item along the first line of your scoring algorithm where it says score. So if the score happens to be a 0 and the patient has no symptoms, which we'll look at again in a moment, we would ask that you provide the patient handout on what are ACEs and what is toxic stress. Those are two handouts we'll be providing to you in English and Spanish. They are in your packet.
Hey, Clarissa, can you pause for just 1 second? We don't have that page in the packet. The scoring page.
No,
the next page in the.
No, you won't
skips.
have this. You won't have the scoring algorithm in your packet. You have the tool. So I was just asking you to refer to those two scoring boxes.
Yeah, we're gonna need that.
Are you going to email this out to us afterwards?
Yes, of course.
Okay.
Chris,
Yeah,
I
you'll
just
have
wanted to add. So as we go through the presentation, if we notice any changes, I'll finalize the slides for everybody, and I will email it to Kelly and your leads so that they can distribute it to all of you.
Okay, thank you.
Of course.
All right. So back to the scoring algorithms. So we would ask that you hand out the two patient handouts. What is toxic stress and what are ACEs? Again, those will be provided to you, and we'll go over them in just a moment. If the score in the boxes on the ACE-Q, when you add the top and the bottom together, if it's a 1 to a 3, and they don't have any symptoms, we would ask that you go ahead and provide the patient education handouts on what are ACEs, what is toxic stress, and building resilience, because we know the family already is experiencing some ACEs. And then the provider would make the appropriate referral to CC4C, which provides care coordination up until the 5th birthday and services, or triple B parenting, parents as teachers, and that we would help families with some of the protective factor education, which are nutrition, sleep, physical activity, mindfulness, coaching apps, and then mental health services, or having that healthy relationship with a caregiver. Then we could also consider in-house referrals, and the provider may schedule a follow-up with this child in 6 months to monitor how they're doing. Now, we have identified high-risk patients, high risk for toxic stress if their score is between 1 and 3, and they're already experiencing physical manifestations or symptoms of toxic stress, or they have a score of 4 or greater without the presence of symptoms, with or without. we know those families are at higher risk. So again, the referral services, you can see there. For this piece, we would ask that you look at, again, the patient education handouts and consider other clinical interventions. And it's likely that the provider will schedule a follow-up in 1 to 3 months, depending on the severity. All right, next slide. So I've alluded to this many times. So these are the symptoms of toxic stress. And you will see this again in the presentation that we send you. And it's also actually lovely built in your EHR. So it creates a lot of ease with which to document. So think back when Murnell was talking about the science of ACEs and how it can clinically manifest in the body. You'll see the same systems involved in this checklist. So across the top axis, you'll see the neuroendocrine, inflammatory, and unhealthy coping mechanisms that we typically see as correlated symptoms of toxic stress. And then on the left side axis, you see these symptoms broken down into age groups primarily. So you see in the bottom under endocrine and the infant or young child, a potential symptom there would be failure to thrive or frequent infections from the inflammatory immune side. And the patients that you'll be looking at, the 3 to 5 year olds, you might see under endocrine GI, constipation, abdominal pain, or you might see things like frequent or recurrent asthma exacerbations, despite the fact that you feel the family is fairly well controlled. If there's just some component of asthma or eczema that seems to be very difficult to stabilize or control, that might be linked to symptoms of toxic stress. So we would just ask the medical providers to consider that along with the patient's score. Next slide. So how to document?
One is Carissa.
Yes.
Can you hear me?
Yes.
Okay, this is Dr. Pat. I have a couple of questions about the previous slide. One is, do you have studies that show these are the symptoms that are exacerbated by toxic stress? Like the one that gets me is kind of like autism diagnosis. Like that almost makes it seem like it's linking, saying there has to have been stress for someone to be autistic or something like that. So I think it'd be helpful from my standpoint just to see the evidence or studies that these are the symptoms or
Sure.
the conditions.
Dr. Pat, we have a really great collateral piece that's been published in conjunction with Dr. Gilgoth, who is our medical director, and she actually provides all of the references for each symptom.
That would be great.
And then she has the reference and then a table of all of the articles that she reviewed in the context of this. And I just was looking, it looks like we have an extra box on that symptom checklist. What that really should say was autism diagnosis / symptoms.
Okay.
Again, we're not saying that, you brought up a great point, Dr. Pat, and I appreciate you mentioning it. We're not saying that the diagnosis of autism is directly correlated to ACEs. It's not that the ACEs have to be present for the diagnosis to occur. What we really mean there is if people are talking about, or if there is some early consideration that there might be an autism diagnosis pending, or you might be getting that kind of referral and further assessment together, or if there are autistic-like symptoms, that in conjunction with ACEs may provide you a better assessment of the risk for toxic stress. But again, we do have the articles for every one of those symptoms. We agree that that's a very important consideration, and it must be thoughtful and well evidence-based for us to ask you to consider that.
And then the other question that I have is the expectation that there's somebody going through this symptom checklist with the parents, or that the physician or nurse practitioner PA is looking at that and saying, does the child have any of these?
Yes, Dr. Pat, you're absolutely right. It's really more, have you considered these things in the course of your history, in that well child visit today? Did any of these things come up? It's not a verbatim symptom assessment for anyone to ask the family members. Okay?
Okay, thank you.
Thank you. Good questions. So, yeah, perfect, Murnell. You read my mind. We have worked with your colleagues and have developed, you guys have developed a wonderful way to document ACE and the ACE-Q scores in your EHR. It's the most beautiful and sophisticated EHR build we've ever seen. So we're very excited to hear feedback from you on how this is going or how we might enhance it. So step one will be for you to go to the clinical form and access the ad hoc forms. I understand that it's in the child folder and then subfolder ambulatory child visit. Next slide. And this should pull up your screening tab on your left, and you type in the word ACEs or ACEs screening, click yes, and this is what will come up. So you can see some normal questions there about your screening page. Next slide. The ACE-Q section looks specifically like this. So the providers will open it up in pediatric view and go to scales and assessments, and they will be able to see the score there. Let's go to the next slide. Let me show you where you'll put the score in. So when the staff pull the screening tools up, you'll be able to check whether the caregiver completed this form or the child themselves. We put that box there in case you ever expand to the adolescent screening. We have an adolescent self-report, so we just built in the opportunity to go ahead and be able to document that for the future if you go that direction. For section 1, you'll document the score. And section 2, on the bottom of the ACE-Q, you'll put the score, and the tool will self-total there. The nursing staff or clinical staff can also, we would ask that you complete whether the patient and family refuse this. This is one of our key metrics, so we ask you to please fill this out if they refuse, and that's fine. If they do, we'll talk a little bit about how to handle that, but just make sure that you note that there. Next screen. So this looks at the top section of what I just showed you, and then the bottom section. So this is the full view where you can see that the provider can hit the button, symptoms of toxic stress or no symptoms. Again, where the patient family may have refused that, who completed it, and the scoring. Then the risk box will be auto-assigned as well based on the score and the presence of symptoms. You as the providers, if you'd like to pick specifically what symptoms you saw or were of concern to you, you can check these in the bottom. But that does not auto-populate the risk component. It's the box in the top left where it says symptoms that creates that additional score that would bump a patient family up to the next higher level depending on their score. And then at the very bottom, you can see the infant component there. On the next slide, you'll see the documentation for referrals. And again, another very nice enhancement of your particular build is you've got these boxes here that you provided the education on ACEs and toxic stress. And then the important box to note here is the referral piece, that you made a referral. Please note if the family is already in services or they are already in services, even if they have a high score, and or particularly when they have a high score and you think, you know, normally you would have referred them to a particular service, but you've already done that. These, again, will likely be the patient families you already know, had some concerning experiences, and you've linked them with the appropriate resources. But check that box because it will help us to accurately calculate the percentage of patients getting appropriate referrals. At the bottom here, you'll see the logistics or the specifics of your scoring algorithm recommendations. And so those are just listed there as a refresher or just to help you navigate what actions you'd like to take next. Next slide.
I have another question about that. If we, and maybe this might even be Kelly that answers this more, but if the CMA or nurse enters a score and then the physician needs to go back in and enter symptoms or what we did, is that ad hoc form modifiable, or once it's been submitted, it's submitted?
We haven't tried that out yet, Dr. Pat, but what will happen is when the nurses do their piece as part of the documentation, as part of their intake, that will pull over into your form. When you go in to get out, all the scores will calculate in and things like that. It should be modifiable because it's an ad hoc form, and all of our ad hoc forms are modifiable.
Okay. Would we have to, when we modify it, say that they don't smoke and don't have Zika travel? I mean, is it going to be, because most of the things, like even if we're changing their weight, it's like making us say they haven't traveled. Okay. When we change a weight or something, it always makes us do those. When we go in, it tells us to do it again.
Really?
Yeah.
And
So
our form,
but so there's a different form for providers to fill out with this?
It is, but what happens is, though, we'll show it to you where you get to it, but what happens is the nurses do it as part of their intake, and then once the provider goes to their form for them to be able to, you know, do what they do, the scoring or however, it brings over everything that the clinical staff put in theirs. So it's bringing that back over here. So then from there,
and then where does it come to, like our inbox to tell us we need to do it, or?
No, it won't. It won't.
Okay.
It lives under location.
Okay.
There's a drop down there, and then that can work.
How will we
remember? It'll show up in the scales and assessment section. And in the beginning, we're just piloting it. Remember that we're only doing a 3-year-old and a 5-year-old well child check. That's it.
Okay.
As part of the pilot. So always for a 3-year-old and a 5-year-old well child.
Just plan on
that's what you would plan on doing. So just always do that as part of their intake. You know, as long as the parent agrees to do it. But we would be doing that as part of the 3 and 5.
Where is the scales and assessment?
On your workflow page.
Hey, guys.
Like where we should.
No, it's where you see your vision, hearing, and PSQ9, PSY. Those.
That's not
Kelly?
where I find it.
Dr. Pat?
Yeah.
Can we table this and put this at the end so we can get through? I don't want to take up the recording time either, but we'll absolutely.
Actually, how do we do it? We'll table it.
Thank you. I know you need to kind of work through this a little bit. Practice would be helpful. Okay, let's go back to the slides here. So I think we were just starting to look at the outcomes. So I think next slide or 2. Okay, perfect. So we have 4 primary outcomes that we like to measure with regard to the implementation of ACEs. Number 1, of course, just the % of patients screened over the eligible in a given month. So an important consideration will be to make sure you're using the right visit type when you assign patients for scheduling appointments, because we're looking at and pulling data from the 3- and 5-year-old well child visits over, and on top of that, to create our percentage will be the number of patients actually screened. We'll then look at the percentage of patients with a positive score, and those are going to be patients in the intermediate or high risk groups. Again, with the definition of the positive per your scoring algorithm, those will be patients with a 1 or greater, essentially, for our data calculation over the percent or the number of patients that were screened. Then, of course, we're going to look at whether or not the positive patients had documented referrals. So, important thing here for this data to be accurate, what we're really trying to see is that patients have been referred appropriately. That's completely dependent on whether or not we document that. So an important thing to consider, to please make sure you fill out that referral box and help hold each other accountable, whether that's the nurse that knows the referral's been made or the provider, just to make sure that's been addressed. The last box you'll see there is the percent of patients refusing screening. So again, marking that on your EHR build will be important as well. All right, next slide. So I want to start by preparing, let's start by doing a little bit of role play. We've got a good bit of time here, just the perfect amount. So I'd like you all to pair off and just ask each other, what are ACEs? I heard something on the radio about ACEs, which I actually did the other day. There was a great NPR study on it. So I heard something about ACEs. Do you know anything about that? And just practice telling each other what you know about ACEs and toxic stress. We're going to give you about 5 minutes. What would she do? So, I wonder if I can clock in there. What? Huh? Oh, yeah. Okay, cool. Oh, very good. Thank you.
Yeah, whatever. Yeah, I mean, I'll do whatever. Yeah, I don't even know how far that is. That's what I thought. So, and there are, should be what, 5 of us? Oh, it's a Wednesday. She does. I'm gonna get something. Yeah. I can show you. Yeah, since I'm the big time, we're checking as that education right now, so we're not actually typing anything. It's part of the ad hoc. That's cool. Oh, yeah.
All right, everyone, let's try to come back. I want to hear what your thoughts were and how you did. Kelly?
Yes, ma'am.
I'm going to ask you to pick on someone and tell them to tell us what their experience was.
Bree.
Yay, Bree! How did it go? Was it easy to talk about ACEs?
Yes. Everybody seems to pretty much have a hand or know exactly like what it means to the patient and the family.
Yeah, I think it's, I think that when we get comfortable just talking about ACEs, and I had to really practice and find a little speech that worked for me, families really, really do respond generally very positively to the fact that we care about them. It is important to set the right tone to make sure that we say things like, we want to know what you've experienced so we can provide the best care possible for you, or because we care about you. So let's go to the slide before, Murnell. And these are a couple of other things that you can say to families when you're talking about ACEs. Just to say that ACEs are common. I generally, the first time I talk to a family about it, I say what ACEs are. Like, ACEs are adverse childhood experiences, or just really difficult things that we go through in our lives. And then after that, I use the term ACEs, or difficult experiences, just to not reinforce the word adverse. It makes a really nice, a name for our initials, adverse childhood experiences. But I think it's good just to be sure that we use language that the families can understand and that is culturally and personally sensitive. Another thing, just an easy thing to say with regard to toxic stresses, the more ACEs you have, it increases your chance of toxic stress.
You still there, Carissa?
We may have lost her, but she will be coming back shortly.
That's okay. One of us can take over. So I think what Carissa was saying, one thing that you can talk about with families is that the more ACEs that you have, the greater your chance of developing toxic stress. The fact that ACEs accumulate over time. The older that a child gets, the more likely they are to have more ACEs, and that ACEs, the number of ACEs never goes down. We can't unexperience something. So when a child has experienced one ACE, they will always have that ACE. That is something that may continue to accumulate over time, and that number would never go down. Their score would never go down. We know that ACEs, without that key buffering protective factors that we talked about, at those key developmental stages, without the protective factors, can increase the risk of toxic stress. That's something that you could address with patients and families. And the fact that stress can bring illness, both physically and mentally, to patients and to children. So these are all some key concepts to address with patients and families about ACEs and toxic stress. Just some very sort of short bullet points.
Hey, Lena.
Yes.
We just missed everything you said. So basically about for the last like 2 minutes or so, we missed everything. You were gone, completely gone.
Yes. 1 second. We will fix this.
Okay, can you hear me now?
Now it's echoing. So
Okay. Oh, Carissa is back.
you might need to take the Skype volume off because when you say anything, it's like echoing throughout the room.
I'm back. I'm so sorry. I had a little power outage. Very interesting. So sorry about that. And then the last phrase, I just like to remind people that when we experience toxic stress or toxic levels of stress, it can make us sick, both mentally and physically. Next slide. Well, 2 slides. 1 more. All right, so here's a sample script that we will be providing for you. I believe it's in your packet there in front of you, about when you're handing the tool out, some things that you can say, things that might make it a little bit more comfortable for you. And so just starting out by saying we have some forms that we'd like you to fill out so Dr. Pat understands better how your child is doing. Or this one is called the ACE screening. We have all of our patients 3 and 5 years old fill it out so we can understand what they've experienced. And again, just reinforcing, you don't need to write yes or no by any of the items. Just please put the number of things you've experienced in the box on the right. All right, and now I would like for you all to practice. Actually, let's go through the provider script before I have you practice. The provider script really is more geared toward what you might say to a family if they have a positive ACE-Q, or why, if they ask you, why are you asking me about this? And so the easy thing for me to say is we ask about ACEs because we want to understand what you and your child have experienced, and the better we understand you, the better we can work together to support you or keep you well and healthy. A nice way to bring up or a way to break the ice about some symptoms that you might be seeing that you're concerned about with relation to toxic stress is to say, because of what your child has experienced, I'm concerned that this may be contributing to some of the problems like we're seeing, like a recurrence of bedwetting or frequent abdominal pain, just to say something like that. And then to have a positive comment to say the earlier we see patients dealing and addressing toxic stress, the earlier we can intervene and help to make sure everyone's healthy. So let's go to another role play, if you will, and we're going to have you all turn to each other, and if you're a provider, explain what the ACE-Q results mean, or talk as if your partner is a patient family. If you are going to be handing out the patient questionnaire, if you're one of the nurses, explain to your partner why you fill it out and how you fill it out. Okay? Take a couple of minutes to do that.
Is there another name we can call it? Because they already do an ASQ and then an ACQ. We're talking about how that's like super confusing, like ACQ
Where they take one versus the other, like, however, you know, like, we could cross them more.
We haven't done one.
I told Free, I was like, that We're still on, and can you hear? Come right here, Kelly. I mean, I don't know, maybe she would hear you. Lena or Carissa?
Yes.
We can't hear you all and haven't really been able to hear you all for about the last 5 to 7 minutes, and now the screen is just playing.
Okay, we are working on our slide deck, or something with Zoom is not working. But
We are
we're
trying to get
working
the
on
slide
that.
deck
And
up
can
and
you
running.
hear me better now?
I can hear you better now, yeah.
Okay.
But it's just the blank screen and it says your name on it.
Okay. Yeah, we're bringing the slides back up.
Okay. And once you went off the first time, Lena was talking, but she like froze and we didn't hear anything.
Huh, okay. Thank you. If I need to go back, I will.
Okay. And I don't remember where you were when it first cut off. And then you came back on.
Okay.
Yeah.
I know where I was.
Okay.
All right,
Okay,
thank
good.
you.
Yeah, that makes sense.
Kelly, can you guys hear me now?
Yes, we can hear you.
Can you see the slides?
Yes.
Okay, we're back. Sorry about that, everybody. Technical issues. Okay.
Yeah. They're doing it at Myers Park. I'm going there tomorrow. Sorry about the technical issues.
If we could come back, I'd like to hear your thoughts. I was just talking and talking away, and I realized I was muted. I'm so sorry. Will anyone be willing to tell us how it went when you were actually practicing with the patient family? I hope somebody played a really unruly, difficult family. Did anybody do that? Y'all are too nice. I would have absolutely done that to my partner. Oh, good, good, good. Somebody tell me how it went.
Yeah, we were from Philly.
I told everybody to mind their business.
And we was like, it's none of your business.
So I
If
tried.
my daddy's in jail. Like, we were really nasty with it.
I love it. I love it. So that may happen to you. And so here's what I would suggest doing. I would just smile and say, okay, no problem. You do not have to fill this out. We ask everyone that's 3 to 5, so I really hope that you will know that we aren't trying to target anyone. We just care about our families. And if you don't want to tell us about that, that's fine. We want to work with you. Here's a handout on ACEs, though. If you're curious about it or what we were asking about, please read that. And if you don't want to read it, throw it, wad it up and make a basket on the way out.
Recycling.
That's what I say. Something like that. Sometimes I say you can make a paper airplane out of it. So just don't worry about that and just note what the family said. So I want to take you through a couple of case studies before we go over the patient education materials. So just a refresher, when you're thinking about your scoring algorithm, if you have a patient family that scores a 4, what is their risk level for toxic stress likely going to be?
Higher.
Very good, very good. Next slide. So this is a sneaky case study. We didn't talk about this earlier, but this is a very important comment and item I'd like to bring up. We have some extensive writing about this topic in the implementation packet, which you will be receiving. So in the instance that the score is a 10 on the top section only, not when it's a 10 when you add the top and the bottom. Only when it's a 10 on the top, you know that the patient or family has noted that they have experienced all 10 ACEs, and therefore one of them is absolutely one of the reported mandated reportables related to abuse. So when the score is a 10, you just would tell the patient family, it looks like you've been through a lot. Because you've experienced all of these items, we are required to report per our policies, and then you just follow that normal policy. Now let me tell you, in the 6 practices that we have worked with thus far, all of them had a major concern that all of their families, or at least a high number, were going to write a 10 on their questionnaire. And I understand that. I'm a nurse and a social worker, so I understand the implications. Thus far, out of all those pilot sites across the country, we have yet to have anyone fill out a 10. Now, we've had some high scores of 8s and 9s, but no 10. And so I just encourage you, it may happen. Maybe you guys will be the first practice, and we will learn from you, and we'll get a sense of how that went. But you are likely going to discover mandated reportable issues, not from this screening tool, but from your normal clinical expertise assessment and history that you do every day, and how you screen for those items like sexual abuse and physical abuse, how you screen for those every day in the course of your practice. This tool is really created to be a screening tool for the presence of toxic stress. So please don't be concerned about, if it's an 8 or a 9, or even if it's a 1. That one thing could possibly be sexual abuse. The expectation is that we would ask you to use your clinical judgment and ask the family, is there anything you'd like to tell me about with regard to this ACE score? If they want to tell you or disclose, they will. And if they're not ready to, it doesn't matter if you ask them a yes or no by each of these questions. They would not disclose that information. We do have a brief or a summary with regard to how we have come to the decision to provide this guidance around a score of 10 from our legal counsel and experts across the country. So that is available to you if you would like to review it. I understand it is a serious and concerning item, but again, from all of our experiences thus far, we've really found that the ACE-Q tool creates the opportunity, plants a seed to talk about these types of very meaningful and risky things for children who might be experiencing them. And we've seen more disclosures about what's going on in the family when this kind of environment is set. Lena, is there anything you'd like to add?
I don't think so. I think you covered it, Carissa.
Okay, thank you. I want to transition now to some patient education materials that we'll be providing you. So if you remember early on in your scoring algorithm, I talked about the patient handouts on what are ACEs and what is toxic stress. If we can advance to those, Murnell. Those should also be in your handout. So these three patient education tools are going to be some of your best friends. We've provided them there. You'll also have them in PDF in English and in Spanish for your clinic. The first one, What Are ACEs, is the tool we'd ask you to hand out to any patient family, whether they complete the assessment or not, but it is the specific intervention when the score is 0. If the score is 1 to 3 with no symptoms, we would ask that you hand out the 2 handouts there on the left of your slide. So what are ACEs and what is toxic stress? And if the score is a high risk, we would ask that you hand out all 3 of these. And again, we'll talk a little bit more about some things that you can say with regard to the patient education handouts. And we have provided what we call job aids there in your packet to give you an idea of some things you can say consistently across providers when identifying or using these handouts for either patient education or anticipatory guidance. So let's look at the next one, Murnell. So I often say these 2 things with regard to this handout, which I think you've heard me say. I like to interject some humor whenever I can. And so I typically will say, this is a patient handout on ACEs. When I first heard of them, I didn't understand what they were. Why do we always have to have a fancy name for something in the medical field? But ACEs are really difficult experiences, and there's been research on these and how they affect the body. And the 10 most damaging ACEs, or the most difficult experiences, are listed here on this handout. And just be helpful for you to know about them so you can make sure your family has the opportunity to be as healthy as possible. For the toxic stress handout, this one does a great job helping families to make a link between toxic stress and how it could affect our bodies and our minds. So I say having a lot of stress over time, over a long time, can make people sick. Do you think this could be happening in your family, or do you think this could be part of the reason why little Timmy has so many stomach aches? Or just to say, you know, we want you to understand this so we can help. All right, next slide. So remember, when you're talking about ACEs and toxic stress, if the patient doesn't seem receptive, just give them a handout and just tell them, read this if you're interested. And, you know, you can make a joke about if they're not interested, you can throw it away or whatever. But just make sure that you convey it. We understand if you aren't willing to take the questionnaire or if you're not receptive to talking about it, but we still want to provide you some education. Be sure to use open-ended questions if the patient family does want to talk to you about their ACEs. And if you're worried that, and you guys know these families, you know exactly the ones I'm talking about, that if you ask them to tell you what's going on in their lives, they're going to talk for several hours. There may not be that many of those, but you know who they are. That you go ahead and say, what are you most concerned about? What can I help you with today? And you know, convey it in a way that I know we're not going to solve all the problems in the world today, but what can I do today to connect with you and help you? And again, just remember, as you know, with your clinical expertise and your clinical judgment, not to give advice unless the family's okay with that, about how to handle an ACE or a difficult situation. Next slide. We also like to just remind you that in the context of asking patient families about ACEs, you may trigger some experiences that you have thought you dealt with, or that may be fresh on your mind. But a lot of times just talking about these types of experiences can trigger things in our own lives, or working with a population that is in such great need, that has significant adversity, can be hard on our spirits and souls. We in the pediatric community tend to be some of the most compassionate people in the medical field, and so it's important to think about ways that you can provide self-care to your team and to each other, and think about how it might also be impacting you individually. So we ask that you just be aware of your mind and body. You know, are you sighing a lot throughout the day? Do you notice you are clenching your fists or feel tension and stress in your shoulders? That you connect and be aware that you're already experiencing some signs of stress, and how you can mitigate those, and how you can help to balance those experiences or stress you might be feeling with the things that we know that build resilience. So sleep, exercise, nutrition, great relationships, enjoying your work time and your time off. Be sure to keep connected with people in your office or who you feel could be a good and safe colleague for you to express any concerns about. And then debrief there at the clinic if you have a particularly difficult day or questionnaire incident, or even a positive experience. A lot of times, when I talk to practices who are implementing ACEs screening, I hear a lot of positive experiences that have come out of their screening implementation. So don't forget to debrief and share those as well. Of course, if you're experiencing any long-term stress, or you're really starting to feel the signs and symptoms of burnout, please don't hesitate to contact your employee assistance program. Next slide. So the plan for you all is to go live, well, we've done our training today, and the launch date the week of September 16th with on-site canopy support. Do you need to say anything about that, Kelly or Renee? We may have lost Renee.
Yeah, we're still kind of working that out, Krista, because the binders and stuff still have to be created, and then I know like some of the practices are trying to establish what they're going to do with, you know, if somebody scores in the high.
Okay.
So we're going to need at least a couple weeks from today to get things figured out, because we've still been waiting on the referral, like where we're going to, what resources there are in the community, some kind of algorithm of what to do. And Dr. Maida emailed me this morning with something that she said wasn't in the form to be able to even share yet. So I think before we can set a launch date, we need to make sure we have the plan in place.
I just wanted to add to that. I believe that was Dr. Pat. So Dr. Mehta, and please know Dr. Mehta and the rest of your leadership at Atrium and Novant have been working very hard on putting together a resource binder or resource list for you all, taking into account the ACEs framework and the protective or resilience factors that Carissa mentioned. So that is in development and hopefully will be completed soon. The algorithm that Carissa reviewed will be the one that both Myers Park and Blakeney will be using. Please know that that will continue to evolve as we are able to solidify the various intervention supports for the risk categories. But that is this algorithm that both Myers Park and Blakeney will be using. And we are happy to answer any further questions around referrals and intervention resources as over the next few weeks as you all figure this out and solidify your plan to move forward.
Also, I don't know if it's relevant, but you don't have the names of the clinics accurate on the slide. So we're Charlotte Pediatric Clinic, and Blakeney is one of us, like Charlotte Pediatric Clinic Blakeney, and then there's Charlotte Pediatric Clinic South Park, which is here, but Myers Park is, it should just be Myers Park Pediatric, maybe?
Yeah. Okay, they're not part of Charlotte Pediatrics. Okay, yeah. we will note that. Thank you.
And then I think the last slide just gives us the contact information. And we certainly are available for any additional questions or specific items that we've talked about today. If you would like those sent to you individually, they are all included in the implementation guide that the practice already has a copy of, and we will be making sure that we send the slides out to you as well. So please feel free to reach out if you have any further questions. I think we have 2 whole minutes, if there are any questions that we can answer, or if there is a question we can answer right now, or if you'd like that time to go back over some of the EHR slides. I know Murnell has already sent those to Dr. Pat and Kelly.
So Dr. Boson has a question.
Yes.
And this goes back to the scoring page that you guys showed. We don't have, but there was something on there for the intermediate risk where they have the 1 through 3 risk factors, but no symptoms. Recommended referral to CC4C. So are we supposed to refer everybody with a risk factor? Because it seems like that might overwhelm our referrals.
No, that's certainly based on the provider's judgment. It would be something for you to consider there. Okay. However, when we were on site, we met with the leadership of CC4C and the Resilience Project, and they were very open and welcoming of your referrals as they have revamped some of their systems and are wanting to make sure that they target patients in this age group and having to do with these particular experiences. So they're welcoming of your referrals.
Okay. I guess I was just looking at the risks, and it seems like some of them are like a separation from a parent, and I feel like or parental separation, and I just worry that if we're sending every single patient whose parents don't live together, who may not have any symptoms to account to CC4C, that we may not have their resources available when we need them.
Sure, and I understand that completely. Again, we would ask you just to use your clinical judgment. The scoring guide or the scoring algorithm provides clinical considerations. If you feel like a patient family is dealing well with the separation, there are no symptoms, and they're not open to it, or you don't think it would be appropriate, you don't have to refer them. We would ask you to do what you feel is the best thing to do. think about this too. They are 3 and 5-year-olds. So at a score of 3 in a 3-year-old, that might very well be a patient that would need a referral. But a 1 and a 2 is really going to be up to your judgment. The scoring algorithm, again, is to set some guidelines around where you would consider the patient's risk level.
Yeah, I feel like that's, I guess, maybe where we just need a little, or I personally would just need a little bit more guidance and training. Is, I mean, we can complete the questionnaire, but for me, figuring out who is recommended to be referred or sent somewhere, because it looks like on here similar recommendations for like the intermediate and high risk.
Well, if you see over on the high risk, it's kind of all the stuff in intermediate plus, there's a little plus sign there, referral or link to the trauma-informed care therapeutic services, or maybe the appropriate medical provider. So if the patient is having encopresis or a new onset of bedwetting, or maybe just wetting pants all around, you might want to consider referring the patient to a urologist. And then following the medical follow-up in a more timely manner. It might be 1 to 3 months where you're talking to that patient family. So again, this really shouldn't change the way you're currently practicing in your office as much as giving you a framework with which how to intentionally talk to families about these issues and thoughtfully consider where you might refer them. Right now, you're not asking these questions, and you don't have this kind of guidance to say a 2 is different than how I might want to refer a patient who has a 5. So just think about this laying over your clinical judgment and expertise. I consider it like an additional vital sign or an elevated WBC. There's some further assessment that needs to go on, some further discussions. And I think one last point I really would like to share with you is that from our focus groups and from our own research, we have heard over and over from patient families that they feel like just talking about ACEs with their provider is an intervention. They feel like you showing that you care about these things and you asking them to consider the impact of on their health and well-being helps to make them more resilient. So they see the discussion as a resilience thing, and this is just planting the seed. You're not going to solve all the problems in one visit. It may be that the patient family doesn't really want to talk about what kind of referral they would be receptive to that day, and you have a high risk score. So you would say, I understand completely. Here's some information to read about it. Could I see you back in a couple of months and we could talk about this further? I mean, if they're not ready to talk about it that day, you're not going to make a referral. That's okay.
Okay, that's helpful. It's just hard to tease out like you were supposed to do with that.
Yeah, it's very intimidating to think I'm going to close this loop out today in this visit. Yeah, so it's not going to happen very often, if ever.
Thank you.
You're welcome. Thank all of you for your time. We appreciate it so much. You're going to get some information on how to evaluate this training. Please let us know how we can do better for the next group. And we really appreciate your time today. And let us know if there's anything we can do. Hope you guys have a great day.
Thank you all. Thank you all for your time.
It's just so everybody knows.